Real important topic, something that all of us deal with every day we operate is our OR staff, and we know that they can make or break our days, and many of us are experiencing the breaks right now as there's a national staffing shortage, and the ramifications of that. I was talking to Lee Rubin earlier. It's just we see how much we struggle when we don't have our our A teams with us. So no relevant disclosures to this talk. This is about teamwork. It's about relationships. It's about setting an example. This is not about complaining to administrators about how you need better staff. That's not how you win this battle. That's not how you come out on top. That's not how you make your day better. This is really all about working well with people, treating people with respect. And I can stop the talk right there and be done. But actually, I was surprised to see how much literature there is on this subject about team relationships and relational coordination in the operating room, and how we communicate with each other, and how we ask for an instrument, and how we react when things go well, and how we react when things don't go so well. And researchers can listen to these conversations, record the conversations, or be in the operating room, and behavior kind of falls into different categories in how we interact with staff. And some of these are very positive, some of these are very negative, and most of the time it's kind of in between. But there are certain relationships and how we communicate that affect staff performance, that affect staff buy-in, their willingness to sort of go the extra mile to be a great team player, and to not only make your patient's experience better, but also to to get you out earlier potentially. And this really highlights the central role of mutual respect in working with OR staff. And this can be your anesthesia team, your circulators, your techs, your radiologists who are going to come in and run the fluoro for you. You need to have relationships with all these people. And one of the important takeaways from this is that this is not based as much on roles, meaning you as the surgeon, you don't have this inherent natural relationship with people just because you're the surgeon and they're the x-ray tech, and there's that dynamic that's defined by those roles. This is based on longitudinal communication with your staff, and the longer you get to know this staff and work with them, the better these relationships and communication styles work. And this highlights something Dr. Moskow was talking about earlier, which is consistency in the operating room. The more consistent your staff is, the better these things will be. In an ideal world, you'll work with the same team every single time you operate, or the same group of people every single time you operate. And when that happens, things tend to go well. This is a study not from orthopedics, but from general surgery, looking at the preparation time to set up a hernia repair. So a pretty basic operation. And to set up a hernia repair, you can see that best case scenario, the staff's doing it in 4 minutes. And at worst case scenario, they're doing it in 27, 28 minutes. So a lot of variability setting up a very simple standard procedure. And what they did is they sat down and they decided to dedicate a consistent team to this after 200 cases of measuring data. And what they found was that things got very consistent in terms of team performance. So just the simple fact of having a consistent team that does the same things day in and day out goes a long way. And these concepts have been shown in orthopedic surgery as well, in spine surgery, and total joint surgery. The same concepts apply, not surprisingly. How do you affect this? How do you do this? I think this means partnering with your OR administration, your leadership, and again, not demanding things, but trying to make a case and working with them and being a good team player, and continuing to bring this up, that you need consistency to perform well. On that note, sort of interoperative handoffs are things that we've looked at and presented at ACUS last year. When we have a handoff in the middle of the case, I'd say none of us think that's optimal. It's a necessary thing often to give staff their needed breaks, but if we can minimize when these happen and try to time them around less critical events in surgery, or time them around things, maybe turnovers, that would be better. What we found when we looked at this is that turnovers, we looked at 4 years of data at our place, and looked at how this happened. And it turns out we had an intraoperative handoff of a scrub tech to scrub tech relieving each other about half the time. About half of our cases we were able to do with no staff turnover. About half the time we had a turnover in the case. And about 10 to 15% of the time we had more than one turnover. So how did this affect things? So when we had one scrub tech handoff in surgery, it prolonged the surgical time somewhere between 4 and 6 minutes. And when we had 2 handoffs, it was more like 16 to 18 minutes. And these were on logistic regression, so controlling for all the other variables that we could possibly control for. So these are things that you want to minimize. Again, these are things that you're going to have to negotiate with your hospital leadership to try to do. Or if you're lucky enough to work in an ASC where you have control of these variables, you can design workflows to eliminate this if possible. And interestingly, these were the biggest variables in terms of what increased operative time were scrub tech handoffs, as big as almost any other demographic variable here. So again, this falls largely on us, not on Periot, not on hospital administration. The more you can do yourself to improve your staff dynamics, the happier you will be. And it's up to the surgeon to really establish this culture. It comes from us. We shouldn't rely on anybody else to establish this culture. And this means doing things like showing up on time or early. Always walk in the operating room, as soon as you get your scrubs on, say hello to everybody, ask what you can do to help. Be part of the team, help to open up trays if you need to help open up trays. On the occasions where you need to help clean rooms to make the room turnover better and faster and more efficient, don't be afraid to pitch in. Do not disappear between cases and have people call in to track you down to try to start a case. Always be available, always be ready to help, and always be ready to do what you need to do to keep the day moving and get everybody moving forward. Make it easy to solve problems. These are 2 things that we brought into our operating rooms within the last 2 years that have helped a lot. We have a cart in every operating room of kind of 99% of what we use in a case. So if we drop something or something's missing from the pack, or we need a second thing because something got contaminated, we can just go to this cart and find what we need. Outside the operating rooms, we have an emergency cart. Our central sterile is 3 buildings and 2 city blocks away. So if we need something, it used to take 45 minutes to get something. Now it's right outside the operating room. We have all of our critical things that we could possibly need here, right outside the operating room. And minimizing variability is really helpful. We want to design our procedures and our flows and our days to minimize variability, because variability makes it more difficult for staff to do their work. This means the room setup, the same every time. Draping, the same every time. Try to use the same instrumentation. Try to use the same implants. I know we love variety. I know we love trying new things. It'd be great, for many of us to use a different knee for every system. But what that does is that slows staff down. It slows down central sterile. It makes people unfamiliar with things. And as much as you can, try to be consistent with vendors, instrumentation, implants, closure. And just as importantly, try to standardize with your partners. This is hard to do sometimes, but if you can have your partners who operate on different days than you doing the same way to drape a total knee, that goes a long way to making things easier for everybody to do their jobs. We streamline our trays. We cut back significantly on our trays to make it easier to set up, to make it faster to set up. We used to open a reamer tray for every case. I use 6 reamers out of that reamer tray ever, for 99% of my cases. So we just started putting those 6 reamers in another tray, and that saved our staff from having to open a reamer tray every case. The Hawthorne Effect, you may be familiar with this, the concept of making work visible. This goes back to the Western Electric plant where turning on the lights made people more productive. So measuring output or making people aware that we're looking at these things can improve performance. You have to do it delicately. We have a whiteboard in our operating rooms where we do a very simple tracking method where we document time in, time of spinal, incision time, closure time, turnover time. This holds everybody visibly accountable to their part of this team flow. There are some other creative things that some institutions have done. This came from Shock Trauma, where our course director worked at, and this is after I rotated there, but they designed a financial incentive program to reward people with really small amounts of money for keeping the turnovers less than 60 minutes. And before doing this, they were able to do that about 30% of the time. After invoking these small financial incentives, they were able to do that 50 to 60% of the time. And over a 2-month pilot program time, they saved about 13 minutes per turnover. And over 2 months, that ended up being about $177,000 in savings. They improved their first case on-time start significantly, another $33,000 in savings, so over $200,000 in savings in terms of just efficiency. Any idea what this program cost in incentives? $8,000. So really a great investment here. There are more complicated ways that you can do this. We're working on some of these, but you can really take this as far as you want to. It's a big topic. But in conclusion, we're the captain of the ship. We need to lead by example because our staff will follow our lead. And these interpersonal relationships and consistency with staff are the most critical thing. And we need to take a proactive role in doing this because when we do that, our OR days can flow smoothly, our cases can proceed with minimal stress, there's less wasted time, and we're getting home earlier to our families and our lives. And most importantly, this is giving us the ability to deliver a great product to our patients. Thanks.